probably since 2015 to come up with a way for the doctors to be able to see what the true price is and what the patient's going to pay at the pharmacy for their drug. And part of the problem was, we started out 20 years ago with a formulary and benefit file, which is a static file that has information in there, but there's so much more information that's available directly from the payer. So what the real-time benefit check on the pharmacy side and what's integrated into the EHRs today is for the doctor to not only see what the patient is paying, but also if there's alternatives available, something that's not always available in those formulary files. The other issue is prior authorization, and you're going to hear a lot if you're attending the AMA session. They're talking a lot about prior authorization and the need to make sure that the patients are getting through their prior authorizations. So when you look at real-time benefit check from a provider side and a pharmacy side, there's a lot more than just the drug price that's in there. What we're planning on doing with the CARIN Alliance is to actually bring that real-time benefit check directly to the patient, whether it's through an app or through the payer portals, different ways that you can do that. And I think it's important to understand that it's not just that price, but also for the patient to understand, are there alternatives available? Do they have to go through prior authorization? Are they going to have to make sure that they're staying on top of getting that drug, from the pharmacy and getting that drug to be able to take that medication? So we're not as far along as the other groups. We're just getting started. We've had a couple of meetings now, and we're actually really excited, especially with the new rules that have dropped, and also getting a lot of interest from both the HL7 side and CPDP, members of both organizations attending, as well as the EHR's payers, and would love to have your input on that. The goal is to come up with an IMP guide that would really go across all the standards development organizations for people to be able to bring that to the patient.
Question for Chris? Yes.
So how does this fit in with the Da Vinci initiative?
Yeah, so we actually are going to be also working with Da Vinci as well. There are use cases right now, they have specific use cases they're working on, but actually a colleague of mine is the program manager for Da Vinci, so we're kind of working in sync to make sure that one of the Jocelyn Keegan,
So Da Vinci and Argonaut and CARIN are working in individual swim lanes. We're talking frequently, but we're working very hard not to overlap or duplicate. The goal is we've got plenty of work to do. Let's just figure out what everybody's doing and go with them to make that happen. Good question.
Yeah, so on the policy side, what we're doing to make sure that PBMs are opening up those APIs for patients and for intermediaries who are working with patients. So those things, the PBMs have this stuff locked down, titers and analogies I can't use. And it's an impediment right now in terms of getting access to patients.
Well, so I started. Yeah, so those are great questions. So I actually started out on the PBM side, and I completely understand that, but SureScripts, PBMs, they've actually implemented this into the EHRs. They have opened up the data.
EHR to function PBM, no big deal.
Right.
Patient PBM, whoa.
Yeah, and I think, but you'll see like Humana, right? So if you're a Humana patient, you can actually go in the portal and see your patient cost for a drug today. I will say the one thing that we are going to work on, especially on the CARIN side, is that cash price, because the cash price is not necessarily available through the PBMs. Not saying that it couldn't be available, but that's why we have a lot of the PBMs and the payers at the table, and SureScripts as well, to make sure that we do understand that that's an important.
Herein lies so this is why I'm excited about not just being one more conversation on a 10-year journey of technical work. We're multi-stakeholder by design. Some folks are saying, hey, I want to know the price the plan pays for the drug overall, because I'm a doctor and I'm under total cost of care risk. So I need to know that. So having a debate about the data model and understanding that the primary audience for said data model would be the patient gives us a lot of room to talk about what is achievable. Then the big debate is what's legally required and what can people voluntarily do to break the ice to show that it's in the art of the possible. And oftentimes these are done one-offs. Look at my patient portal, But to the extent we do it in an industry documented, standardized method, then others can follow the same recipe. And it's funny, you know, everyone's got projects of this sort. Walmart has I found this to be very funny. We were trying to get all the pharmacies to do Blue Button area. Remember Blue Button for the pharmacies? And what ended up happening was Walmart said, hey, we will give you on Walmart.com a medical expense summary file that tells you your cash paid claims alongside your PBM reimbursed claims into one organized, completed field. That's probably the most comprehensive meds list of anyone that's been produced in traditional med. It's the Walmart medical expense summary file, right? And I don't know how interoperable that is. And, you know, Sheree, for you accessing that in the New Jersey, of course the answer is no, we know that. So it's not a data feed because we haven't built the standard around it. So the hope, let's make us feel uncomfortable, Arian. Let's make us feel uncomfortable. Let's work it out in the community. And as people start having heart attacks, we sort of figure out, is there a regulatory lever? Is there a voluntary adoption lever? Do we need Devin to clarify that this is actually appropriate and legal and meeting the rules? So let's bring all voices to make sure that this content goes. If that's not too stressful to the
Not at all. We're ready.
Yeah, and the dynamics that's just on the ground, to Aneesh's point, that's happening right now. We have third-party apps going, we're going to use this data, we're going to do it, we've got amazing things planned for it, here's all the use cases that we've got going on, and then we've got the industry going, hold on, I'm not giving you pricing data. No way that's happening. No, that's not happening.
And we call SEMA, and SEMA says, well, maybe we want to have SEMA involved.
That is the real life discussions, right? So we have SureScripts and Walgreens on one side, and we've got GoodRx and you know, and all these other organizations on the other. They're having legitimate
one side, one
discussion.
table,
one round table, right?
Yes.
Let's make that happen. But they're good dialogue, and everyone is there for the express purpose. To Aneesh's point as well, what we have found is there's all these business-to-business interoperability initiatives that are going on. We fully support them and say, absolutely, go forth and prosper, do it all. That's awesome. And we hope we'll continue to make that happen. But on the business-to-consumer side, we found that we don't get into issues with regards to business models, right? Competitive issues. This idea that you want to empower the consumer allows us to have a more expansive conversation as to what the data should be. And then as we use and we develop these reusable artifacts, they can be used anywhere that they want, right? Whether that's to make that happen.